All right, let's talk about something I see almost every single day in the ICU, metabolic acidosis. Now, I know what some of you might be thinking. Another complex topic, another list of causes to memorize, but I want you to forget all that. Today, we're not studying a topic, we're going to solve a case. We're going to be detectives. So picture this. You're in the middle of a busy shift. Suddenly, alarms start screaming. You grab the latest blood gas result off the printer and, boom, the pH is in the toilet. Your patient is crashing and they're crashing fast. What's your first move? This isn't some textbook question. This is real, the clock is ticking, and what you do next matters.
Okay, so let's dive right in. Now, before any good detective can solve a crime, they have to understand the crime scene. So what exactly is going on in the body, and, more importantly, why is it such a life-threatening emergency?
At its absolute core, metabolic acidosis is all about one thing. Your body is losing the battle against acid because it's running out of bicarbonate. You can think of bicarb as the body's chief buffer. It's like a sponge that soaks up acid. But when that sponge gets completely used up or you just start losing it, there's nothing left to stop the pH from plummeting. And that's when all the body's systems start to short circuit. And when I say short circuit, I mean catastrophic failure. A profoundly low pH is a flat-out 5-alarm fire. The heart muscle gets weak and just can't pump effectively. Blood vessels go floppy and blood pressure tanks. And here's the real kicker. The vasopressors, the very drugs we use to raise that blood pressure, they just stop working. It's a terrifying, vicious cycle, and that's why we have to act so quickly. So how do we start to unravel this mess? Well, thankfully, we have one incredibly powerful clue that can break the entire case wide open, and that is the anion gap. This is our first and our most critical diagnostic step. And the best part is, the math is incredibly simple. You just take the sodium and you subtract the chloride and the bicarb. That's it. A normal gap is going to be somewhere in that 8 to 12 range. But, and this is key, if that number starts creeping up, especially if it goes above 20, that should be a huge light bulb moment for you. That's a massive clue telling you there's some kind of unmeasured acid building up in the system. You can think of it like this. The body is obsessed with electrical balance. The positives have to equal the negatives, no exceptions. We measure the big players, sodium on the positive side and chloride and bicarb on the negative side. That little bit left over, that space, is the anion gap. It's full of unmeasured negative ions. When some new mystery acid shows up, it fills that space and makes the gap bigger. Our job as detectives is to figure out what that acid is. So here's the bottom line. This one simple calculation is a fork in the road. It splits our entire investigation into two completely different paths. Is the anion gap high? Then we are hunting for an added acid that has been added to the system. Is the gap normal? Then the problem isn't an added acid, it's a loss of base, a loss of bicarbonate. Two totally different cases. So, let's go down that first path. We've got a high anion gap. We know there's a mystery acid on the loose. It's time to pull out our list and round up the usual suspects. And in the world of critical care, our go-to list of suspects is the famous gold market mnemonic. This is our rogues gallery. It covers the big hitters, from dangerous toxins like glycols and methanol to the byproducts of a sick metabolism like lactic acid and ketones, all the way to straight-up organ failure, like when the kidneys just can't do their job anymore. Let's start with the most common offender we see in the ICU, alpha-lactic acidosis. When a patient is in shock, their cells are essentially suffocating. They're starved for oxygen. To stay alive, they switch to this backup power system, anaerobic metabolism. The problem is, this emergency generator is really dirty. It spews out a ton of toxic exhaust, and that exhaust is lactic acid. Another major player is key, for ketoacidosis. This is what happens when the body's cells can't use their primary fuel, which is glucose. The classic example, of course, is uncontrolled diabetes. The body gets desperate for energy, so it starts burning fat like crazy. Now, that might not sound so bad, but the byproduct of burning all that fat is a flood of acidic molecules called ketones, and they quickly overwhelm the system. Okay, but what if the anion gap comes back normal? This is where things can get a little tricky. It's a more subtle kind of case. The alarm bells might not be ringing as loudly, but the danger is every bit as real. This sends our investigation down a totally different path. So in a normal anion gap metabolic acidosis, or NAGMA, the problem isn't a new acid being added. No, the problem is that we're losing bicarb. But remember, the body has to keep its charges balanced.
So to make up for that lost negative bicarb, the kidneys desperately hold on to another negative ion, chloride. The result? The chloride level goes up. So in these cases, the gap isn't the clue. The high chloride is.
So where's all this bicarb going? Well, the number one culprit, by a long shot, is GI losses. We're talking severe diarrhea where you're literally just pouring out bicarb. You can also have kidney issues where they fail to reabsorb bicarb. And this is one we really have to pay attention to, there are things we do as clinicians that can cause it.
And this is a perfect example and a huge clinical pearl. Think about how much normal saline we give our patients. We pour it in by the liter. But here's the deal. Normal saline is packed with chloride, and it has 0 bicarbonate. So what are we doing? We're actively diluting our patient's bicarbonate and replacing it with chloride. We are causing a hyperchloremic metabolic acidosis.
Now, I know this can all seem pretty complex, but in practice, we use a systematic approach, a roadmap, to guide us. You see the acidosis, you calculate the anion gap, and that one number points you down the right path. It creates order out of chaos and keeps you from getting lost in the weeds.
Okay, let's put all the pieces together. We followed the clues, we've explored both lines of investigation, now it's time to crack the case.
So here it is, side by side. On one hand, you have high anion gap metabolic acidosis, or HAGMA. The gap is high, the chloride is normal, and the problem is a gain of acid. You're thinking gold market. On the other hand, you have normal anion gap, or NAGMA. The gap is normal, the chloride is high, and the problem is a loss of bicarb. You should be thinking about diarrhea or that big saline infusion. This right here is your cheat sheet at the bedside.
And please don't ever think these normal gap cases are rare. Studies have shown that more than 19% of patients in the ICU can present with this. It is a huge part of our daily practice, and it's often hiding in plain sight.
So if you only take one single thing away from our time together today, let it be this. Start with the anion gap. It is your most powerful, most high-yield first step. It's the move that brings order to the chaos and turns a confusing, scary clinical picture into a puzzle that you can actually solve. So we did it, we cracked the case, we identified the culprit. But this is where the next challenge really begins. Because knowing why your patient is acidotic is one thing, knowing how to fix it is something else entirely. The treatment for methanol poisoning is worlds apart from the treatment for diabetic ketoacidosis. So remember, the diagnosis, that isn't the end of the story. It's really just the beginning.